Well, thank you very much, Roy. It's a pleasure to chair this panel on a very important and timely subject, something that has a great deal to do with human health and the prevention of disease. The reason for this panel relates to the recent publication of new guidelines for the treatment of high blood cholesterol levels. And these guidelines depart from previous guidelines issued by the National Institutes of Health and the NHLBI. And the departure has created some controversy in the scientific community over how to treat and who to treat and when to treat people who are at risk for heart attacks. Although the number of heart attacks has been going down in our society, the deaths from heart attacks have been going down, they still account for about 30% of all deaths. So nearly 1 in 3 people will die as a result of heart attacks or strokes. The disease is called atherosclerosis, and the culprit that causes atherosclerosis has been identified. And can I have the first slide, please? This should be the first slide on Dr. Goldstein's presentation. Do I forward that? Okay. Yeah. Oh, there it is. Okay. So what we're going to be talking about today is a cholesterol-carrying protein called low-density lipoprotein, or LDL. Some lay people refer to this as the bad cholesterol. LDL is produced in the body. It circulates around in the bloodstream, and it is removed. Its job is to deliver cholesterol to a variety of cells that need cholesterol, and the excess cholesterol is removed, the excess LDL is removed from the body by receptors that are on the surface of liver cells that take up and degrade the LDL particle. And people who have lots of LDL receptors have low LDL levels and low incidence of heart attacks. People who have deficient LDL receptors, the LDL builds up in their blood and they have a high incidence of heart attacks. And you'll hear today from our panel the evidence that LDL is the culprit that causes heart attacks. So we know the ultimate cause of heart attacks, and what's even more exciting, we have ways to prevent these heart attacks. The development of the statin drugs, pioneered by Roy Vagelos and his colleagues at Merck, have allowed us now to administer agents that lower LDL and are demonstrated to reduce the incidence of heart attacks. And the question then is who to treat, when to treat, and how aggressively to treat. And that is basically the topic for which these advisory panels have been constituted, and which will be the topic of our discussion this morning. Now, the original advisory panel was first issued a report in 1987. It was a panel sponsored by the NHLBI and the American Heart Association. And at that time, they recommended that for people at high risk of a heart attack, that they should have their LDL reduced below 130 milligrams per deciliter. Now, you should know that the average LDL level in a 40-year-old man in this country is about 120 milligrams per deciliter. And, but the initial report said that if somebody was at high risk for a heart attack, they should lower their LDL to 130. But as these panel reconvened every few years and issued new guidelines, and the most recent guidelines, as the evidence came in that the lower the LDL, the less frequent would be heart attacks, the most recent guidelines recommended that the LDL cholesterol be lowered below 70 milligrams for people at high risk. And that has been the recommendation up until last year, when new guidelines were introduced that basically avoided the topic of LDL almost completely, and instead proposed a treatment strategy based on more or less aggressive administration of statins. And so the controversy arose as to whether there should really be targets for LDL, as the original panels suggested. That is, doctors should give enough of a drug to try to get the LDL below 70 in people at high risk, or should they just give a high dose of statin and forget about the LDL? And that is essentially the question that will be addressed, and we have people on the panel who are on both sides of that issue. We're very fortunate in our panel that we were able to invite and receive acceptances from 4 of the real experts in this field. So what you'll hear today in the discussion is literally from the horse's mouth. I will introduce, the scheme is that each of the panel members will make a brief introductory statement. I've asked each one of them to address a specific question in this field, and they have a few minutes, and they can show up to a couple of slides, and that's supposed to be very brief, I reiterate. And then we'll have an open discussion among the panel members, and then we will open it up to the floor for questions and your opinions as well. So to begin, let me introduce the first panelist, my long-term 43 years, not 43 years old. Actually, we've been scientific partners for more than half of our lives. Joe Goldstein and I have been working together at UT Southwestern Medical Center since 1972. And Joe is a Regental professor and chairman of the Department of Medicine, chairman of the Department of Molecular Genetics, actually technically my boss. And as Roy mentioned, we shared the Nobel Prize in 1985 for the discovery of the LDL receptor that removes LDL from blood, and we've continued to work in this field. So Joe, what is this? What is the evidence that LDL causes heart attacks?
Thank you, Mike. Good morning, everyone. So the New Yorker magazine presumably got wind of our meeting today, and in this week's issue, they have a cartoon that summarizes the essence of what this panel will be discussing. And if I could have the first slide. Oh, great. So let me read it if you all can't read it. Your best cholesterol lacks all conviction, and your worst is full of passionate intensity. So speaking of passionate intensity, your chairman and I think most of the members of this panel are passionate believers in the fact that LDL cholesterol is the initiating cause of coronary disease. And then there's 4 lines of evidence that supports this. It's really quite an amazing amount of data that's been accumulated over the last 100 years. And the first line of evidence was experimental evidence, and exactly 100 years ago in 2004, a Russian pathologist fed cholesterol to a rabbit and produced atherosclerosis. And since that time, that experiment has been repeated thousands of times in every species from pigeons to humans. And it's impossible to produce atherosclerosis in an experimental model unless you elevate the cholesterol, typically by feeding a high cholesterol saturated fat diet, but also in mice one has genetic mutations that elevate the cholesterol. So the evidence for experimental seems to be incontrovertible, but I think even stronger is the genetic evidence that comes from a disease called homozygous familial hypercholesterolemia. And these children are born with no LDL receptors, and as Mike mentioned, LDL receptors remove LDL from the blood. And as a result, their LDL level is high, in this particular girl, was 783 milligrams per deciliter from the time of birth, whereas in a normal individual at the time of birth, normal humans in all species average about 30 to 40 milligrams per deciliter. So an enormous increase in LDL, and as a result of that, it's deposited in her skin to produce these cutaneous xanthomas. It's also deposited in her coronary arteries, such that at age 3 she had angina, and at age 6 she had a heart attack. And Mike and I once saw a child who was 6 months of age in Toronto who has this disease that had her first heart attack at that age. So there's, this is the nature's example of a pure LDL that produces severe coronary disease. There's no hypertension, there's no diabetes, there's no smoking, and there's even no type A personality. So this is, I think, unequivocal evidence, and the parents of these unfortunate children, the children are rare. It's only 1 in a million. The parents about 1 in 500, and they have cholesterols, if untreated, LDLs that are about 2 to 3-fold above normal, and they would begin to have heart attacks if not treated at all at as early as 30 to 35 years of age, and they represent about 5% of young individuals who have heart attacks in the country. Now, in the last few years, scientists have discovered an inherited single gene mutation that elevates LDL receptors and produces a lifelong decrease in LDL. And in prospective studies, this lifelong 30% decrease in LDL leads to a 90% protection in coronary disease. And this involves this system called PCSK9. Time doesn't allow me to go into all that, but if one can, this is a newly discovered molecule that destroys LDL receptors. So there are many companies now working on antibodies that will actually counteract the effects of PCSK9 and mimic what you see in these patients who have mutations in the PCSK9 that elevate their receptors. So that's the genetic evidence, and then one has the epidemiologic evidence, and I won't say much about that. You'll hear from 2 expert epidemiologists talking about that. But the first epidemiological study implicating LDL as a risk factor for atherosclerosis goes back to 1955 by a scientist called John Goffman, who used the newly discovered ultracentrifuge. He was the first person that really separated lipoproteins into good cholesterol, HDL, and a bad cholesterol, LDL, and he made this correlation, and it's stood the test of time. I don't think there have been really hundreds to maybe even thousands of confirmatory studies, and you'll hear more about the epidemiology. And so, and finally, to really make sure that the epidemiology is right, one basically now has therapeutic evidence, as you've heard from Roy and Mike about statins, and with the introduction of statins, one's been able to do prospective studies in high-risk patients, and you'll hear more about that. But there's been a meta-analysis by Dr. Collins and his colleague Richard Pito of more than 150,000 participants at high risk for coronary disease in 26 prospective 5-year trials, and they've shown clearly that a decrease in heart attacks is directly proportional to the decrease in LDL. So to put all this together, one basically has 4 lines of evidence that supports the idea that LDL cholesterol causes coronary disease, and this has come about from the last 100 years of research, most of which has been done in the last 30 or 40 years, but it began 100 years ago. And I think there are very few, if any, chronic diseases of adults that have been subjected to such intensive scrutiny. And never has the cause of a chronic disease and the approach to its prevention so convincingly demonstrated. So now I think you'll hear from the rest of the panel about how one should treat LDL and when and how long. Thank you.
Okay, thank you, Joe. Our next panelist is Professor Sir Rory Collins. He is at the University of Oxford in England. He's co-director of the Clinical Trial Service Unit and the Epidemiological Studies Unit, and a professor of medicine and epidemiology. And he's also chief executive of the UK Biobank, which is really an incredible venture in which genetic and clinical phenotyping information is being obtained on hundreds of thousands of people and will be made available to the general public to look for correlations between mutations and disease. Professor Collins is also the leading and most inventive, I think, person doing clinical trials today in any field. And he's conducted some of the most important clinical trials of statins and measuring their effects on heart attacks and strokes. And I really don't trust any trial unless Rory Collins is involved. So with that, let me introduce Professor Collins, who will try to summarize the evidence of that lowering LDL by various means reduces the incidence of heart attacks.
Thanks very much, Mike. I think one can't really understand the evidence unless one understands the methodology. And the problems that we're seeing at the moment in terms of confusion around both the efficacy, but particularly the safety of cholesterol-lowering therapy represents a failure to understand how you evaluate therapies. And so my first slide is just going to describe methodology, because as I say, if you don't understand that, then it's very easy to get the evidence wrong. And I mean, all of you will be familiar with the concept of the randomized placebo-controlled trial, but it's quite clear when one looks in the medical literature that most doctors, most scientists don't really understand why it's done. Why do we do randomized trials? Can I move this on? Thank you. So randomization ensures that we have groups of patients that differ only randomly from each other. And the beauty of that is we then give one group a treatment and the other group not. Now, that sounds incredibly obvious, but it is, in a sense, magic. It produces a situation where we avoid bias. At the moment, what we're seeing is a lot of claims in journals and in the media that drugs like the statins cause lots of side effects, based not on randomized evidence, but on observational studies, where people get very large databases, very smart statisticians, big computers, and they try to adjust for all of the differences between the people who get a statin and the people who don't, and they can't. You can't adjust for the things you measure with error, and you can't adjust for the things you don't measure. Randomization ensures you have that balance. More importantly, what they forget is when they compare people who are taking a statin with those who are not only do the people who are taking a statin differ, for good reason for the ones who are not taking a statin, but they've been told that they're taking a statin. They've been told when they start, look, rarely you can get a muscle problem. If you get a muscle problem, come and tell me. Now, the ones who are not getting the drug are not told that. So, of course, the people who get the drug know what they're doing, the doctors know that they're taking a tablet, and by telling them they're going to get a problem, they report problems. And so in randomized trials, we also blind. The patient and the doctor don't know whether they're getting the real thing or the dummy thing. Now, this is kind of very obvious. I realize most of the people in this room understand the concept, but it's so critical to understanding the efficacy and safety of treatments that I wanted to reinforce it. Because the randomization ensures we're comparing like with like, and the blinding ensures that the outcomes are assessed equally in the two groups, and that cannot be achieved in any other way. And that means that we can assess not just efficacy, but the safety of the treatment reliably. So this is a meta-analysis of all the published data on muscle problems and on liver problems. Now, muscle is the thing that's most commonly reported by people who are on statins and go back to their doctor and say, I'm getting a side effect. And if you look in the observational studies, there are far more people who come back who are on the statin saying that they've got muscle problems than those who were not given the tablets in these very large databases. But in the randomized placebo-controlled trials, there is no difference. That's because the treatment doesn't actually cause it. It's telling someone that they'll get a muscle problem that causes it. So the randomized placebo-controlled trials show there is no excess of muscle aching. The statin intolerance that one keeps hearing about is actually a myth. It's not supported by the evidence, actually refuted by the randomized evidence. Next slide, please. And if we look at the meta-analyses of the randomized trials, as was mentioned, there are some 170,000 patients that have been randomized, either between statin or control, or more intensive statin versus standard statin, in about 27 different trials. And if we look at the effects in those trials, we see on average per 40 milligram per deciliter reduction in LDL cholesterol, a reduction of about 1/5 to 1/4, 20 to 25% proportional reduction. And what this figure is showing, the solid vertical line indicates no benefit. To the left of the line, you can see all the results are piling up consistently for people with or without previous coronary disease, with or without diabetes, male or female, young or old, slimmer or not so slimmer, smoker or not smoker. Consistently, per 40 milligrams per deciliter, a reduction of about 1/4 per 40 milligram per deciliter. And then there have been trials that have looked at more intensive therapy that have showed that if you then reduce LDL cholesterol by another 40 milligrams, you reduce the residual risk by another 20 to 25%. And even among people who start with an LDL cholesterol less than 80 milligrams per deciliter, lowering their LDL lowers their risk further. So this is a very exciting finding because it indicates that adding newer agents to the statins, such as the PCSK9 inhibitors or potentially the CETP inhibitors, by lowering LDL further, should lower risk further. And in terms of the absolute benefits, it's important to understand that what I showed you was the reduction per 40 milligram per deciliter. But typically, if you give a good dose of a statin, and at least in the UK, 20 to 40 milligrams of generic atorvastatin is what's used most commonly, that will lower your LDL not by 40 milligrams, but by about 80 milligrams per deciliter. So you lower your risk by 20 to 25%, lower it by another 20 to 25%, so you can get a 40% proportional reduction in your risk, just with a standard statin. So in absolute terms, what does an 80 milligram per deciliter reduction in LDL cholesterol achieve within about 5 years? Well, in high-risk patients, that is patients who have already got vascular disease, they've had a heart attack or a stroke, got peripheral arterial disease, hypertension, diabetes, you'll prevent about 6 to 12 per 100 from having a heart attack, a stroke, or needing revascularization over the next 5 years. In the lower risk groups, in primary prevention, the types of patients who are now being offered statin therapy with the new guidelines, it's still about 3 to 5 per 100 over a 5-year period. You need to contrast that with the hazards in terms of the absolute increases in adverse events. This treatment is phenomenally well tolerated, and that's been demonstrated by the randomized placebo-controlled trials. The only really serious side effect is this rare complication of myopathy, where you get muscle weakness or pain associated with big increases in the muscle enzymes. But that occurs in 0.05%. So not 5 in 100, not 5 in 1,000, but 5 in 10,000 per year compared with the benefits. There appears to be a similar excess of hemorrhagic stroke, but the reductions in ischemic stroke, that is strokes due to clots rather than strokes due to bleed, is much bigger typically. And then the randomized trials have also identified that there is a small increase in the incidence of diabetes. And what it turns out is that it appears to be earlier diagnosis by a few weeks or a few months in people who are close to being diagnosed as diabetes. So we've got benefits which are more than 10 times the hazards associated with statins, even in the lower risk patients. So when you read about statin intolerance, be very careful. The evidence is really refuting the idea that large swathes of patients actually get real problems with the statins, except for the problems caused by the media and their doctors telling them they're going to get a problem. Thank you.
Thank you very much, Professor Collins, for that really very eloquent defense of randomized controlled trials, which are, in a sense, at the heart of everything we should be doing in medicine. Our next speaker, so what you've heard so far from Joe Goldstein is the 4 lines of evidence that LDL is responsible for coronary artery disease. You heard from Professor Collins that lowering LDL has been clearly demonstrated to reduce coronary events. And then we come to the key question: how do we decide who to treat and when to treat, and what should our target of therapy be? And that's where the guidelines that I mentioned earlier have come into play. And we're fortunate today to have Donald Lloyd-Jones on the panel. Dr. Lloyd-Jones is at Northwestern University in Chicago. He's the Senior Associate Dean for Clinical and Translational Research and the chair of the Department of Preventive Medicine at Northwestern. Dr. Lloyd-Jones has been not only an expert in preventive medicine, but he's also been a very influential member of the most recent panel that issued the new treatment guidelines. And Dr. Lloyd-Jones will tell us about the old guidelines and the new guidelines, how they differ and why. Donald.
Thank you, Mike. Well, it's a pleasure to be here this morning. And I'm actually performing double duty. Your program mentions that Dr. Scott Grundy was to be here. Unfortunately, he couldn't join us today. So I will be representing Dr. Grundy as well as the more recent guidelines. Looks like we have a little mismatch between Apple. It means I get a little bit more time, which is good stuff. Little mismatch, I think, between Apple slide formats and Windows slides formats, but I'll try to walk you through it. So the most recent guidelines that were published by the NHLBI actually date back to 2001, and this was under the aegis of the National Cholesterol Education Program, which really is the program that, thanks to all the evidence Dr. Goldstein reviewed, put cholesterol on the map as a really important public health issue. And I think that is actually one of the terrific public health successes that we can point to that has largely driven much of the decline, not all of it, because we've had successes with smoking cessation and other things too, but has driven much of the decline in deaths due to heart disease and stroke that we've seen over the last 4 decades. So the National Cholesterol Education Program convened their 3rd adult treatment panel, which was published in 2001. And this was really a revolutionary document because by this time we had enough clinical trial evidence to really start to bring into focus who were the groups where we saw high enough risk to expect real benefit from putting them on a medication. And Dr. Grundy, who couldn't be with us today, really was the pioneer and the guiding force behind those tremendous guidelines, which for their time were, I think, extremely forward-thinking and extremely groundbreaking. And what Dr. Grundy's group did, I think, was codify a really important paradigm into our treatment approach for prevention. And that was, summarized in the statement you see here, the intensity of our prevention efforts should match the absolute risk of the patient. If you think about that for a second, I think it's a very important but simple statement. Patients who are at low risk for a disease should certainly benefit from lifestyle interventions. Anyone, even a young person, should be told to stop smoking, and we should provide them with whatever help they need to do so, because we know that smoking over the long term is going to increase their risk, not only for atherosclerosis, but for a number of other chronic diseases as well. But patients who have not just low risk, who need lifestyle therapy, patients who are at higher risk, we ought to be a little bit more intensive, right? The clock is ticking for those individuals, and therefore it might merit using drug therapy in addition to lifestyle in order to prevent an event that is much more imminent. So what this requires is an understanding of who is at risk in the nearer term so that we can select those individuals who are at higher risk and be more intensive in our therapy, target those individuals potentially for drug therapy where there's some benefit, but there might be some harms related to drug therapy. But that's tolerable because of their higher risk in the short term, and layer that on top of our intensive lifestyle modification. So the approach that the third adult treatment panel took was really to understand the patient's individualized risk as much as possible. And they identified groups that were at particularly high risk, where they thought the clinical trial evidence that was beautifully reviewed by Dr. Collins clearly merited intervention with drug therapy. Those individuals with existing coronary heart disease, by 2001, clearly we had enough evidence to say they should be treated with LDL-lowering therapies. Individuals with other forms of atherosclerosis that was already clinically manifest also should be treated. And these are individuals who might have atherosclerosis of the lower extremities causing something called claudication or leg pain with exercise. Other types of atherosclerosis that had already manifested clinically. Those individuals, again, had been studied in enough clinical trials. We knew that LDL-lowering therapy was important for them as well. Individuals with diabetes tend to have not only a higher risk for coronary heart disease, but also worse outcomes once they develop it. And so individuals with diabetes were also identified as a group at high enough risk to think about drug therapy. And finally, they understood that there are a large, in fact, the bulk of the population does not yet have atherosclerotic disease or diabetes, but is walking around with an array of risk factors. And you heard some of them mentioned: hypertension, smoking, adverse levels of other things, family history. And when you kind of count those things up in this paradigm, you can say, this individual looks like a higher risk individual. I might want to consider drug therapy in that person, but how do I quantify that? So they started by counting those risk factors, but then they also said, let's use some science. And by this time, there was some very good epidemiologic data from a study called the Framingham Heart Study to suggest we could actually be reasonably precise in putting people into bins of 10-year risk using not very sophisticated equations. Basically understanding their cholesterol level, their blood pressure level, whether or not they had diabetes, whether or not they smoked, their age and their sex. And this was a population of Caucasians only. We could use those variables to quantitatively predict what their risk was in the next 10 years. And this group said, if that risk is over 20% for a heart attack in the next 10 years, and here the focus is just on heart attack, we think that's a high enough risk group that we should go ahead and treat those individuals, even though they don't yet have atherosclerotic clinical disease. They also said if that risk is between 10 and 20%, we're kind of on the fence. You know, we might consider drug therapy for those individuals, but it's starting to get perhaps close to the margin. And if individuals have a 10-year risk less than 10%, then we probably would push lifestyle, but there's not clear benefit to putting those individuals on a medication yet, because we just didn't have a lot of clinical trials in primary prevention, as it's called, at that time. So the paradigm for ATP3 was to initiate lifestyle for anybody who needed it and drug therapy for those people who needed it, considering both that calculated risk level as well as what their LDL level was. And this table just kind of briefly shows that once you've calculated that, you would initiate LDL-lowering drug therapy. What you can see is that circa 2001, down at the bottom here, there was really no clear preference for what type of drug that should be. The recommendation here is to start a statin or a bile acid sequestrants, things that bind cholesterol in the gut so we excrete it, or niacin, which also called nicotinic acid, which at the time also had some evidence that that might be useful for LDL lowering. So there wasn't a clear preference for drug therapy choice at that time, but there was a clear indication that people at high enough risk should have their LDL cholesterol lowered in order to reduce their heart attack risk. And then if that LDL goal was not achieved, and I'll look at the targets in a moment, then there was a recommendation to intensify therapy with more statin or other drug, or start to use combination drug therapy. So by 2004, a number of other trials had come out, and there was an update to ATP3 that was published, which you see here, and again, really pioneered by Dr. Grundy's work. And you can see here's basically the treatment matrix. So you consider on the left the risk category. Is this a high-risk patient, a moderately high risk, a moderate risk, or a lower risk patient? And that basically tells you, do they already have coronary heart disease? Do they not have it, but they're at high enough risk? And in what risk category are they? More than 20%, 10 to 20%, or lower than that. And then after you did that, then you had to say, okay, what was their LDL cholesterol? You know, if they're in this risk group and their LDL is over a certain threshold, I should consider initiating lifestyle. If it's above a different threshold, then I should also consider drug therapy. And I should shoot for a target on the right column of an LDL less than 100, perhaps less than 70 for particularly high-risk patients, or less than 130, less than 160, depending on the risk level. So this was grounded in sort of secondary analysis of the clinical trials that had been published to date. That is, patients who achieved certain levels of LDL did better. But the question is, why did they achieve those particular levels of LDL? In fact, there had been no trials at that point, or even to date, that have really titrated doses of medication to try to achieve a certain target of LDL. And Dr. Collins reviewed for you very nicely kind of the evidence base that some statins better than none, more is better than a little bit, right? And that's, I think, where things stood circa 2004. So by 2008, the NHLBI convened a new panel that was to look at revamping the guidelines. Further evidence had come out. NHLBI said, we want to do this a slightly different way. The prior cholesterol panels had really pulled together a group of acknowledged experts in the field who were able to look over the whole amount of data and say, this is what we think is best practice for medicine. But the NHLBI convened the new panels with a slightly different charge, and that was, rather than provide a ceiling for care to say, how do we manage every single possible situation that we see in clinical practice, let's provide a rock-solid floor. Where do we have our best evidence for treating to reduce heart attack and stroke? So that was really a somewhat different charge for these guidelines, and I think, as we'll find in the discussion, it actually dictates a somewhat different outcome than had been true for previous panels. So perhaps that's the genesis of some of the controversy. And the approach to these guidelines was really driven by the Institute of Medicine's request for clinical practice guidelines we can trust. And again, what that meant in the practice of the guideline panels was, what happens is the guideline panel asks questions that can inform clinical practice, turns those questions over to an independent group. So now that it moves away from the expert panel, and that independent group surveys the literature for relevant studies and grades them for their quality. And only studies that are relevant to the question and are of high enough quality, typically randomized controlled trials, are then presented back to the panel for interpretation and synthesis in making the clinical recommendations. That's a really important process point, but it dictates a different outcome. That process means that as an expert, I can't say, well, this is the best paper in this field, we have to pay attention to this paper, while someone sitting next to me says, no, 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 you're crazy, this is the best paper, we've got to ignore your paper and pay attention to this one. That's what I think leads to consensus recommendations that may actually misguide clinicians and patients. What we're doing here is a different process where we're all going to agree on what is the absolute best rock-solid evidence that provides a floor for therapy. We may not be able to address every situation, but we're going to address those that we have the best evidence for. So in fact, what happened was NHLBI got out of the guideline business. As this process neared its end, they felt that it was more appropriate for professional societies to put these guidelines out than for government agencies. Between you and me, I think that NHLBI was very conscious of what had happened with the mammography guidelines for breast cancer screening and the highly politicized nature of guidelines in this era. And I think that I can certainly understand why they want to get out of the middle of that. I think a government agency should probably remain above all this. And so they turned our work over to the American College of Cardiology and the American Heart Association, who ultimately published the 4 guidelines that had been commissioned by NHLBI. They focused on lifestyle, on weight management, on risk assessment, and on cholesterol treatment. Very importantly, all the panels adopted the same paradigm. We think this is actually a pretty smart approach to understanding how we should treat our patients to reduce risk. And that is, again, the intensity of our preventive therapies should match the absolute risk of the patient. So I'm going to focus in mostly on the cholesterol and risk assessment guidelines today. That's our charge, and certainly that's where there's been the most discussion and debate. What we found when we were presented back with the best evidence, which again was largely from randomized clinical trials that Dr. Collins have described to you, was that there were 4 groups that clearly had benefit from being treated with statins. And there is no question that we focused in on statin therapy for all the reasons that Dr. Collins told you, because it is clearly the most efficacious group of medications that we have developed to date, and it is also clearly safe. There are other medications that lower LDL, but they just don't meet those same standards of safety and efficacy as statins have done to date. And they haven't been studied in as many patients, admittedly, as well. So we found 4 benefit groups from being treated with statin. First, those with existing atherosclerotic cardiovascular disease, as we've talked about. Second, people with an LDL cholesterol over 190 milligrams per deciliter. And this really enriches the population for those who might have a genetic abnormality that drives up their LDL cholesterol. Third group, people with diabetes over age 40, who because of their constellation of risk factors, even in the presence of an LDL cholesterol that may be quite modest, still are at particularly high risk. And finally, the group that, again, because of their constellation of risk factors, maybe don't yet have diabetes, don't have a markedly elevated LDL cholesterol, but still are at risk over the next 10 years for a heart attack or stroke of higher than 7.5% when we calculate it using a new calculator. And this is an important difference with these guidelines. The previous guidelines had focused on reducing risk for coronary heart disease only, using an equation developed in a population of white individuals in Framingham, Massachusetts. A huge step forward at the time, but it was time to make another step forward. So these guidelines actually developed risk equations from populations of white and African American individuals from across the country, not just in one town, and focused not only on coronary heart disease, but also on stroke, another highly preventable outcome with statin therapy. And the reason for that is when we only focus on coronary heart disease reduction, that really works nicely for white men. But it turns out that women and African Americans have their risk for stroke occur much earlier in life, and their risk for CHD occur later in life. So if we only focus on coronary heart disease, we leave a lot of risk, a lot of preventable risk on the table for women and African Americans. And we felt that was unacceptable, particularly because we have effective therapies to reduce risk for stroke as well as coronary heart disease, and it happens to be the same therapy. It's statins. So focusing on atherosclerotic cardiovascular disease, we said if that risk is over 7.5%, that might be a group where you're going to consider drug therapy. But if it's under 7.5%, you're not quite done. There are other things not in the equations we need to consider, such as, does the patient have a family history of early occurrence of stroke or heart attack? Do they have a lifetime risk? And we provided a calculation of lifetime risk as well that's unacceptably high. For some people, that might be over, say, 40% lifetime risk. Do they have an LDL over 160, where they're kind of in that border zone where they might have a genetic elevation and they've been marinating their arteries in LDL cholesterol for a long period of time? Do they have evidence of inflammation that might indicate atherosclerosis? And this is measured by a molecule called CRP in the blood. Do they have clear evidence already, even though they haven't had a heart attack, that there's buildup of plaque in their arteries? And this is measured by the coronary calcium score. And finally, do they have evidence of that peripheral arterial disease in their legs? So those were extra pieces of information we thought could inform the clinician and the patient in making a decision about whether they want to take drug therapy. And then the next step was talk to the patient, understand that risk that we calculated, understand are there other drugs that they're taking that might interact with a statin that could change the potential risk and benefit ratio. And finally, does the patient understand that risk, and are they willing to take a pill every day in order to reduce it? Are the benefits to harms ratio enough for this patient to consider taking drug therapy? Beyond that, we said, you know, statin's clearly best. If they truly, truly can't take a statin for some reason, there are other evidence-based therapies, not as good, and these are the bile acid sequestrants in particular, not as good, but they can lower risk as well. Likewise, if you haven't gotten the LDL reduction that you'd like to see with a statin, you could consider adding drug therapy on top of a statin, but that's a data-free zone. We don't have many trials that have actually tried to do that, and the trials that have not shown extra benefit. That's a very important statement. So far, no trials have shown extra benefit from adding another medication on top of a statin, and they have shown extra harm. So you need to be very selective, we think, based on the evidence, in which patients you might consider adding drug therapy to. So just to kind of summarize, on the right side, and I don't expect you to read it, this is the clinical workflow of the present guidelines. Basically, you decide, is the patient in one of the 4 statin benefit groups? Do they have clinical atherosclerotic cardiovascular disease? Clearly recommend a high-dose statin for those individuals. Do they have an LDL over 190? Those individuals clearly will benefit from a high-dose statin as well. Do they have diabetes and are over age 40? For those groups, either a moderate or high-intensity statin would be supported by the clinical trial evidence, and it depends a little bit on the situation. And finally, primary prevention situation, estimated risk over 7.5%. You can inform that with other testing. Have a conversation with the patient. Don't mail them a prescription just because their risk prediction is over 7.5%. Have a conversation and understand, you know, what the personalized situation is for that patient, whether the risks and benefits are likely to you know, be in the favor of coming down on the side of treating them. So that's really, I think, where things come home. The take-home points you see there, focus on total atherosclerotic risk, encourage lifestyle motivation and intervention for all, provide statins for groups that benefit, use the proven doses and intensity from the randomized clinical trials. LDL targets, we're just not sure. There's never been a trial that has shot for a specific LDL target. And when you look at all the guidelines around the world, Canadian, European, some other US groups, they choose different levels. Some say less than 100, some say less than 80, some say less than 70. What that tells you is we don't know. We don't know what the right target is. We know that lower is better. I think that is universally acknowledged. But I think how you get lower really matters, and that's what the evidence is telling us. Statins, as you've heard, are very safe. We want to take that patient-centered approach where we engage them in the dialogue, and then we want to follow up LDL testing, because that's really the way to maintain that therapeutic relationship. It's a way for the doctor to understand, is the patient actually taking the drug the way I want them to? We're getting as much LDL benefit as I think we ought to. And are they also instituting those lifestyle changes that are incredibly important to lower the LDL as well? So all these things are wrapped up in the guidelines. That's a very brief summary of a document that's about 100 pages long. But I hope that that sort of sets the stage for what I think will be a great discussion. So thanks very much for your attention.
Okay. Thank you very much, Donald. All right, so you've heard that the evidence that LDL causes atherosclerosis, that lowering LDL reduces heart attacks and strokes, and that the panel has issued guidelines recommending treatment of people at certain risk groups, but not aiming for a particular LDL target. The recommendation is simply that if you're at a certain level of risk, you should take maximal statin dose or a moderate statin dose, and but that the doctor should basically not necessarily even measure your LDL, just sort of blindly prescribe the statin. And that's where the controversy arises, because those guidelines, without a target, without leaving the doctor something to shoot for in terms of what to try to get the LDL down to, creates a difference in medical practice from what has been the previous practice to what these new guidelines recommend. And so our last speaker today is Daniel Rader. Daniel is at the University of Pennsylvania, my alma mater, before it was called the Perelman School of Medicine. I don't know why you would name a medical school Perelman. Anyway, he has a named professorship, and he's the scientific director of the Penn Cardiovascular Institute, the scientific director for translational and clinical research. Dan has been a major contributor to our understanding of lipoprotein metabolism in animals, as well as his work with patients. So Dan, tell us the implications of these new guidelines.
Thanks very much, Mike. Good morning. Mike asked me to address the implications of the impact of the ACC/AHA guidelines on clinical practice. And in my 2 slides, I'm basically going to review the positive implications of these guidelines and then what I would call the unintended consequences. And in preparation for this, I talked to a lot of my colleagues, including clinicians on the front line. So this represents a bit of a summary of, I think, what a lot of consensus opinion is about these 2 topics. So with regard to positive implications, I think there are many very positive aspects of these guidelines that I'd like to emphasize. I think the first that's been widely reported is that there are going to be a lot more patients who are treated with statin therapy if these guidelines are followed. And for example, in the New England Journal, some of you may have seen an analysis of the NHANES data, this very large observational database, suggesting that an increase in statin-eligible U.S. adult population from 43 million to 56 million patients, and of that, a lot of that would be in primary prevention, people whose LDLs are not terribly high, who don't have diabetes, and that would go from about 7 million to about 15 million. So this has been widely reported, and I think it's a good thing. I personally think we underutilize statins, and I think by increasing the total number of people who legitimately need statins based on these guidelines is a very good thing. A second issue is that there will be increased statin utilization for high-risk patients. As Don reviewed, the patients who are at high risk require higher intensity statin therapy based on the clinical trials. And so, for example, in someone with a history of coronary disease, an LDL of 90, under the previous guidelines, even with the revision to 70, that was kind of an optional thing, many physicians said, well, they're at goal, they're below 100, they don't need to be treated with a statin. Clearly, with the current guidelines, anybody with coronary disease, really regardless of LDL, merits treatment with a statin. A third is that there will be increased intensity of statin therapy in high-risk patients. And I'll just point out that a search of our electronic health record at Penn indicated about 40% of our high-risk patients were on relatively low-dose statin therapy and would merit intensification of the dose of the statin. Again, I think this is a good thing. Physicians traditionally have underdosed statins with regard to the clinical trial database, and intensification of statin therapy certainly will be a good thing in the patients who merit that. Fourth, with increased use of statins, and you may wonder why this is a positive, but I'll explain, including greater use of high-dose statin therapy, we're going to see, I think, more issues with statin intolerance, whether that's real or Rory, whether that's because patients are being told they're going to have side effects. Nevertheless, we're going to see more and more of this. We're already seeing it in clinical practice. And I think what this will do, among other things, is prompt an increasing focus on the mechanisms for the myopathy, the myalgias, if that's real, the increased risk of diabetes. And I think in a way that's a good thing. We need to understand these more because these are such safe and effective drugs that even the relatively rare adverse effects that we see from these drugs, we need to understand better. And then finally, a credit to Don and his colleagues, these are simpler guidelines than the previous guidelines. And simple guidelines are more likely to be followed by clinicians and patients, and that there will be greater adherence and therefore improved outcomes. So I think these are very positive aspects of these guidelines, and I want to commend the individuals who put these guidelines together because I think these are what we would predict and are already seeing would be the impact of these guidelines. But now I'd like to turn to some of the unintended consequences, and I just want to emphasize that I think these are unintended, and I think they're not even necessarily reflected in the language of the guidelines if you read the 100 pages. But many of these are because of the way the guidelines have been reported and interpreted and consequences of certain key decisions, such as to take the focus off LDL targets. Looks like we cut off the end of the slide here, but I'll go through what I have. First of all, I think one of the unintended consequences is that there will be less titration of statin dose and less use of non-statin medications to achieve acceptable LDL levels, particularly in patients with more significant hypercholesterolemia. For example, I think we can predict, and in my experience are beginning to see, that based on these guidelines, a patient, even with familial hypercholesterolemia, who might need intensive therapy, including maybe a second drug, is simply placed on a moderate dose of a potent statin and basically told, you're now being treated, no further management. I know that wasn't the intent, but I think that is one of the unintended consequences of these guidelines. Second, in that I'm sure we're going to see, until we have more data, less use of the non-statin agents in patients who are hypercholesterolemic and high risk, but statin intolerant. And I just have a quote here, the kind of quote that we hear. Yes, I know I told you I had a heart attack. This is a doctor talking to his or her patient. And we're at high risk of a heart attack, high cholesterol and high risk of a heart attack. But since you didn't tolerate a statin, we're not going to use any other medication because we don't have any data for it. And while that may be the right thing to do based on the clinical trial evidence, I think many of us would argue that it's not the right thing to do based on the tremendous body of evidence that Dr. Goldstein reviewed, linking high LDL to risk of coronary disease. And in that type of patient, we probably ought to be using what else we have at our disposal. But unfortunately, I think these guidelines actually made it more likely that physicians are simply going to throw up their hands and say, well, you didn't tolerate a statin, we'll just forget about it. The third is that less statin treatment of individuals with relatively low 10-year risk, less than 7.5% per 10 years that Don talked about, but high lifetime risk, including patients with familial hypercholesterolemia. So what I'm getting at here is this focus on the 7.5% absolute risk in 10 years, which admittedly was a continuation of the previous guidelines. But that has, I think, further emphasized or de-emphasized the concept of trying to treat people who may not have a high 10-year risk, but whose lifetime risk might be quite high. And I think one of the things I think many of us agree is that this is a disease that starts early in life, and that ultimately the biggest impact we're going to have is by identifying high-risk people early, even if their 10-year risk is very low, but initiating therapy where appropriate. And again, I fear that these guidelines, because of the way they were reported, may actually diminish enthusiasm for treatment in that setting. I think that one other issue is that that there may be greater utilization with, I would argue, questionable value of some of the other risk stratification tools that Don talked about. Again, we need more data with these. It may ultimately be the case that using additional tools beyond risk equations might be a tremendous way to help us guide therapy in the people who need to take statins for long periods of time. But again, I think right now clinicians are wondering exactly what should I use and turning to some of these tests as a way to try to help make decisions. The last one is sort of cut off here, but I know I said it was a benefit that we're going to have more focus on the mechanisms of statin side effects, but I think one consequence of higher doses of statins is clearly that we will see more side effects related to the statins. And then finally, cut off from this slide, but the final unintended consequence is that the de-emphasis of LDL and LDL targets, I think, has created confusion in the community about the causal nature of LDL in terms of atherosclerosis and cardiovascular risk, and has really resulted in a situation, in fact, where I've heard physicians say it's really not about LDL. LDL isn't really the issue here. It's really that high-dose statin that I just need to make sure the patient's taking, end of story. And I think that we would agree, I think all of us on this panel would agree that LDL is causal for atherosclerosis, and that in fact as we see new therapies coming along, such as the PCSK9 inhibitors, which are LDL-lowering drugs, we are going to have a renewed emphasis on LDL as a causal risk factor for coronary disease. And I think, again, not the intention of the panel, but I think the de-emphasis of LDL and LDL targets has created confusion in a community that has been taught for a long time that we need to target LDL aggressively. So, Mike, with that I'll stop and we'll open things up to the panel.
Thank you very much, Dan, for that really excellent summary of the implications of the new guidelines. And as you can see, there are some differences of opinion on the panel. As Dan said, everyone agrees that LDL is the culprit and we need to lower LDL. But the real question is who to treat, when to treat, and how to treat. And so I'd just like to start the discussion. I don't know who to address this to, Don or Rory. You know, the question is, as Dan pointed out, atherosclerosis is a lifelong disease. We know that atherosclerotic plaques begin to form in the teenage years. That was shown in the Korean War when American teenagers were killed in Korea, and they were autopsied and found to have early signs of atherosclerosis. So it's a very, very gradual disease. And anybody who will have a heart attack in any given 10-year period already must have atherosclerotic plaques before that 10-year period begins. And so the question is, why not treat before they're at such high risk and try to prevent the illness? So I don't know. Donald, since you were on the panel,
I'll start.
what's responsible for this arbitrary 10-year figure?
Well, I think, I don't know if you can dial up my microphone on number 4. I think that, you know, when we're talking about medical therapy, not just lifestyle intervention, which I think is completely appropriate for all of us. And by the way, as an epidemiologist and someone who really believes in public health, that's our real problem. This is a lifelong disease. This is something that we must focus on in utero, early in life, in the lifespan, so that we can really change behaviors. Because atherosclerosis has a genetic basis, particularly for some, you know, a small segment of the population. But this is a disease of our environment and our behaviors in the main, and we must change that. Must. By 2030. We will be spending $819 billion every year on atherosclerotic cardiovascular disease. Now, if you think back a few years, it took moving heaven and earth just to pass an $800 billion stimulus package to save the world's economy. Now we're going to have to do that every single year starting in 2030, unless we can bend the curve of this disease now. So that's the real problem here. Getting from here to there, until we get our children and our young adults off to a better start, we're going to need drug therapy, because there are a lot of events that are already in the pipeline that are going to happen unless we get much more intensive. The reason I think why 10-year risk is chosen as a target, and you know, Scott's really been the pioneer, Scott Grundy, in helping us focus on near-term risk, is again, we're talking about medical therapy. Thank you. We're talking about medical therapy. So, you know, we just don't have the data to know that we could put an 18-year-old on a statin for the remainder of their life and know that that's safe. I personally believe it would probably be a pretty darn effective strategy, because we would nip the disease in the bud very early in its course. And in fact, I'd love to do a trial someday where we would treat, you know, young individuals for 10 or 20 years and then stop the therapy, because we may have arrested the disease at the critical period when it's gathering momentum during young adulthood, and then people may not need lifelong therapy. But that's pure speculation. So I think we do need to focus on targeting our therapy for those individuals at the higher risk. That is going to be a function of age, for sure, but it's also going to be a function of exposure to the other risk factors. I love lifetime risk. I publish a lot on lifetime risk. I think it's a very important concept in order for us to impart risk information to our patients, but I don't think it is yet ready for prime time as a decision aid for drug therapy. I just don't think we have enough evidence yet, although I believe in it.
Well, one of the problems is that such a trial, you know, if you start people at 18, none of us will be alive to see the end of it, totally, even if we take our statins every day. So, so that's, you know, that's where we're going to have to make some decisions that are not based on randomized clinical trials. I mean, I certainly have the highest respect and would love to have a randomized clinical trial for everything we do, but you know, if you take, for example, the number one recommendation in this recent panel is for lifestyle change, which includes exercise. I haven't heard of a randomized clinical trial that shows that exercise reduces heart attacks, but maybe you guys know one.
Well, certainly exercise is part of a cardiac rehab program after heart attack does.
Right.
But you know, I think the other thing is, remember what our charge was from the NHLBI. Our charge was not to lower LDL cholesterol. We all believe that's really important. Our charge was to reduce risk for heart attack and stroke. That's a different proposition. And we have many tools that do that. And I think that exercise and the downstream benefits it provides does do that. But you know, I think for the cholesterol panel specifically, there's no question that because of the very strong evidence base of statins, that was our biggest hammer, no question. And we're looking forward to having more hammers.
Dr. Collins, do you have any comment?
Yeah, I think one should look at the statin trials as being a test of a hypothesis, the hypothesis that lowering LDL lowers risk. They provided the opportunity to really test that well because you could get a big reduction in LDL cholesterol. But I mean, interestingly, the results from the statin trials are entirely consistent with the previous trials of other ways of lowering LDL cholesterol, albeit that the reductions tended to be smaller with diet, with resins, even with ileal bypass surgery. Lowering cholesterol lowered risk. And I think the statin trials demonstrate that really unequivocally. Interestingly, when you look to your question, in the randomized trials, in the lowest risk groups, the proportional reductions in risk per 40 milligram per deciliter reduction in LDL cholesterol were bigger than in the higher risk patients where you've already got disease. So I think that does suggest that lowering cholesterol earlier on, you may see more of the epidemiologically expected effect of those lower cholesterols. But as Donald says, the absolute risk in those individuals will be lower. So it may well be that one wouldn't propose a drug there, but that would be an argument for extrapolating from the trials of statins to say we really need to be much more aggressive in encouraging people to lower their cholesterol through dietary means, in particular reducing the amount of saturated fat in their diet. So I think that the trials can be extrapolated. Extrapolating too far is a problem, but not extrapolating far enough is also a mistake.
Well, the trials are only 5 years, so when you talk about this relative reduction in risk, you have followed, in the HPS, have you continued to follow patients, or were they all, the placebos all moved to statins?
Yeah, so the most remarkable thing in the statin trials is that you run your cholesterol high for 30, 40, 50 years, and then you lower your cholesterol, and within the first year, you see about a 15% reduction in risk per 40 milligram per deciliter. But in each subsequent year, you see about a 25% reduction in risk year on year. So the longer you continue treatment, the bigger the absolute benefit. And then, remarkably, as you say, at the end of the 5 years of the trials, both groups get treated the same way. They don't know what they were on. Many of them will go on statin, many of them not, but it's equal in the two groups. And yet we see the benefit from that first 5 years is maintained. And most interestingly, in a primary prevention study done in Scotland, where they've now followed people through linkage to health records to 15 years, they're actually seeing divergence. They're seeing, even though the treatment is now the same in the two groups, after 5 years of statin versus 5 years of control, they're seeing increasing benefit over the next 10 years. So again, earlier intervention suggesting perhaps bigger benefits.
Joe, you mentioned, and I think it went by pretty fast, that the reduction in heart attacks in people with PCSK9 mutation, especially the African mutation. What does that mean to you?
Well, so there's been a classic study done about 5 or 6 years ago by Helen Hobbs and Jonathan Cohen, and it's also been confirmed in several groups where African Americans have a nonsense loss of function mutation in one of the two alleles for this molecule PCSK9. And PCSK9 normally is secreted into the blood and it degrades LDL receptors, and therefore the LDL level rises. So if you have a reduction in the amount of this PCSK9, then you'll actually have an elevated LDL receptor, and you'll have a lower LDL. And in African Americans that have a complete loss of function of one of their two alleles of the gene, they have a lifelong 30% reduction in their LDL level. And in a prospective study, the way this is done, the NIH has supported a study that's been carried out over 10 or 15 years in which people, middle-aged men, were assessed for their the number of coronary and stroke events over this ensuing 15-year period. So it's a pedigreed series of data, and so one can go into that group, the DNA was collected, and look for this particular gene. And so one was able to show that if you inherited this one mutation that reduced activity of this PCSK9 by 50%, there was a 90% protection in coronary events. This is really quite amazing. So this is the strongest evidence that a lifelong risk in LDL is incredibly beneficial. So this, coupled with the opposite situation where you have no LDL receptors and have the highest level of LDL and have the most fulminant form of atherosclerosis, I think makes it incontrovertible that the lower the LDL, the better, and the sooner you lower it, the better. So, so these are amazing experiments of nature, and so many companies are now competing ferociously for antibodies that will reduce PCSK9, and there are published studies that show a single injection lowers the LDL, this is without a statin, by as much as 50% for over a 3-week period of time. And then also plus statins, it even goes lower. So this is a new therapeutic modality for lowering LDL, and will probably be very useful in people as a first group, those that have had a heart attack and at the highest risk and have never been treated with cholesterol-lowering drugs.
So, Professor Collins has been telling us that for every 40 milligrams per deciliter lowering of LDL cholesterol, you get about a 20 to 25% reduction in events. The people with this mutation have a 40 milligram per deciliter lowering of their LDL, but they have a 90% reduction. And that result also supports Professor Collins' really dramatic conclusion that lowering LDL will reduce events even in the presence of other risk factors, because the people in this population have the same incidence of cigarette smoking, diabetes, hypertension, especially hypertension, which is very common among African Americans. They have all of those risk factors, but simply the 40 milligrams lowering of LDL is enough to essentially eliminate coronary disease, 90% reduction. It's hard to think of another explanation other than that this is due to the lifelong reduction in LDL. And the data are also, Rory, they are also consistent with the population data. So if you look at populations in China, which you have done, where the LDL is habitually low, it is close to a 90% reduction in coronary disease compared to what we see in the Western world. Is that right?
Yeah, I mean, the comparisons both between countries and within countries show that each 40 milligrams per deciliter lifelong is associated with about a 50% difference in risk. Within the randomized trials, we're seeing about half of that epidemiologically expected effect. And if you go to, say, rural China, again, even in rural China, where the LDL cholesterols are probably about 40 milligrams per deciliter, they have lower risk than in urban China, where the averages are around 80 to 120 milligrams per deciliter. So it's a continuous relationship down to very, very low levels.
Very, very, very impressive. Trying to think of a question for Dan. We got to get him involved. Go ahead, Don.
Just to expand on that, I think some really important statements have been made, and I just wanted to kind of highlight those. I think you saw from Professor Collins' data, all subgroups benefit, even people with an LDL less than 100. And this was a really important kind of scenario that we considered in the guidelines. What if you have someone who's had a heart attack already, whose LDL is at less than 100, either naturally or they're on 10 milligrams of pravastatin, which is a relatively weak statin. You know, under the old guidelines, we would say, done, we're at target. But we know from direct clinical trial evidence that is an insufficient dose. That patient should be on, optimally, 80 milligrams of atorvastatin. And I think our approach was not titrate to goal, start high. Start with the most effective dose, which is a high potency statin, and only if you see problems, dial back. And I think that's actually a stronger approach, because we're going to capture then all those subgroups who are likely to benefit and give them the maximal LDL reduction that we can get with the safest medications we have. And I think the other really important point is that LDL reduction works regardless, again, regardless of the LDL level you're starting at, right? And regardless of what your risk profile is, basically. Very important trial now, about 10 years old, called the Ascot Trial. These were patients selected for having hypertension. It was a hypertension trial. But embedded within that hypertension trial, they took patients with very average cholesterol numbers and gave them just 10 milligrams of atorvastatin, a pretty modest dose of a statin. And those patients had a 36% reduction in heart attack risk. Selected for having hypertension, treated for very average cholesterol levels with a modest statin dose, and they reduced their heart attack risk by 36%. That's a paradigm shifter. It tells us we need to target risk and reduce LDL in patients at risk, not just focus on one number, the LDL, because that's a very contextual number. Over 190, absolutely. Even higher than that, even the 160 to 189 range, probably not great at all, especially over the life course. But people with very average cholesterol levels, it matters what risk context that's occurring in. And that's where we can really be a lot smarter about who we want to put on medication.
Okay, we have a few minutes left. I want to open the floor now to questions from the audience. We have somebody with a microphone. If you just raise your hand, there's somebody over on this side.
Yes, I'd like to
Should we, I don't know whether it's customary to ask people to just state their name and...
My name is Larry Houston. I'm a journalist.
Okay.
I'd like to ask Professor Collins, you made the statement that randomized controlled trials have shown that...
That microphone isn't working.
Just want to ask Professor Collins about, you made the statement that randomized trials have shown that there is no statin intolerance, but of course this is a population that's already been washed out of people who were statin intolerant, who couldn't tolerate statin. So what about the patients who weren't entered in the trials?
So the question is really around whether randomized trials do reliably assess safety, because the people who go into trials, maybe patients who would have had problems and who have been excluded. One or two of the trials had active run-ins, so people went on to statin before they were randomized, and so you could argue that those individuals had their problems and then didn't get into the randomized trials. However, even in those trials, 3, 4, 5 years on, one sees no difference in side effects. And in the vast majority of the trials, the patients were certainly excluded for particular reasons, but not for reasons that they had been shown to be intolerant to the treatment. They might have been excluded because they were elderly, they might have been excluded because they had renal disease. Different trials had different exclusion criteria. But the extraordinary beauty of the evidence that we now have for the statins is there have been so many different trials with so many different exclusion criteria. We have trials in renal patients. We have trials in the elderly. We have trials where people started with low cholesterol who might have been excluded from other trials. And if we look in all of those trials, all of those different trials, there is no evidence that allocation to statin is associated with this most common alleged statin intolerance, that is myalgia, than in the placebo groups. For example, in the big trial we ran, the heart protection study, 20,000 patients over 5 years, it's certainly true. Every time the patient came in, we asked them, do you have muscle problem? Every time they came in, 5% of them told us they'd had muscle problem. We asked specific questions. By the end of the trial, 30% of them told us they'd had muscle problem. 30% in the placebo group, 30% in the statin group. And that is consistent across all of the trials.
irrespective of their exclusion criteria, irrespective of whether they had an active run-in or the vast majority didn't. And that is not something that one can say with the observational studies. In the observational studies, people take these big databases. They're not randomized, so you're not comparing like with like. People who don't get statins will have been excluded from getting statins by their doctors for a variety of different reasons, no different from a randomized trial. But importantly, the patient is told, as I said, look, very rarely you can get myopathy, there's serious complications. So if you get muscle pain, come back and tell me. So that's exactly what they do. And it's not blinded in those studies. And so the observational studies, observational epidemiology is great if you're trying to pick up thalidomide. If you're trying to pick up a big effect on an outcome that wouldn't normally occur, then observational epidemiology is fine for the assessment of drugs. But for moderate increases in common adverse events like muscle pain, giving it to older people who get muscle pain, then it is not an appropriate methodology. And that's why I started, not with results, but with methods, because it's a failure to understand the methods that is the cause of actually a huge amount of death and disability, because people are not continuing to take their statins, and they're being dissuaded from taking statins by a misrepresentation of the evidence.
I did my own controlled trial. Before I started atorvastatin, I kept a diary for a month about how stiff I felt in the morning and which muscle ached, just to make sure that after I started the statin, there would be no difference. I think that's a good idea, actually. Yes? Can you get a microphone to this young lady?
Say a young type 1 diabetic, say 22 years old. We know that they're at risk for cholesterol. Should a 22-year-old young type 1 diabetic who's in very good control be considered to take a statin as preventative?
Let me ask Dan. Refer that to Dan.
Well, that's a great question. The question is, should a 22-year-old type 1 diabetic take a statin for life? Of course, you didn't mention an LDL or anything like that, but let's just assume the LDL's fine. So I think it's a great example of someone who clearly is at significantly higher lifetime risk as a result of the type 1 diabetes. On the other hand, we have no data for sure in terms of a randomized trial. We never will in terms of that type of situation. So we have to extrapolate. And I think the short answer is that's the kind of thing that the doctor would discuss with the patient in the office. I think that's what the panel would say, and I would agree, and go through the pros and cons. If I were a physician advising a type 1 diabetic patient of a young age like that, an adult but young in their 20s, I would say I think it's a real consideration. I think if the LDL were 60, it might be different than if the LDL were 130. So I do think the LDL plays a role in that decision. But at the end of the day, yeah, I think it's a consideration given the totality of evidence that we have. But that's my opinion. I'd be curious if others have.
Agree 100%.
So that raises a question about measuring LDLs, because you said you would like to know whether the LDL is 50 or 100. So in listening to the new guidelines, I'm struck by the fourth group, because the first three are essentially what was in the past. The fourth group, which is the real guts of the whole situation, I don't see how you can avoid not measuring an LDL. Patients like targets. If you don't have a target, then the patient won't take the statin if they feel well. So how do you address that point?
So I think what's important to understand is that in order to assess the patient's global risk for atherosclerotic cardiovascular disease, you have to measure their lipid panel. You can't do it without it. So the conversation has to start understanding what their blood pressure level is, what their cholesterol levels are, whether they have diabetes, whether they smoked, whether they currently smoke, how long they smoked if they've quit, what their family history is. All these things are really critical context. And I think one of the things that has been misunderstood is, there's a specific recommendation in the guideline that once you start a patient on a statin, you should measure it, the LDL cholesterol again within 3 months to make sure you understand whether you're getting the appropriate response to therapy. Most importantly, are they taking the medication? because we know about 50% of patients by 6 to 12 months will not be taking the medication. And are they adhering to those lifestyle things? So after that, we say remeasure LDL every 3 to 12 months, because this is a really important part, I think, of the therapeutic relationship with the patient. Now, I still use general targets. Am I getting a 50% reduction with a high potency statin? Am I getting a 30 to 50% reduction with a moderate potency statin? Am I seeing what I should see compared to where we started? But I can't tell them that adding another medication on top of a statin at a good dose to get from 78 to 68 will improve their benefit. I can't tell them that based on any available evidence right now, except for people who get lower do better. People who get lower start with a lower LDL and do better with lifestyle, right? If you give a random group of people the same dose of medication, the ones who do better lifestyle and who start at a lower LDL will get to a lower LDL. So yes, they will do better. But it matters how I do that. And that's what I think we really focused on was, adding niacin to statin caused major excess problems. It lowered the LDL. It didn't prevent any extra heart attacks and strokes and caused major adverse side effects. So I think we really feel that, if you're going to do this, select your patient carefully, understand what the potential side effects are, make sure they're already on a maximally tolerated dose of a statin, and then have a conversation, because you can't tell them what the data is for lowering that LDL further over and above the statin.
Hi, good morning. Brian Harvey, a retired FDA. Later this morning, we'll be hearing from Dr. Mark McClellan, who, when he was FDA commissioner, was a strong advocate for patient-centered health care. And one of the mechanisms for that is over-the-counter medicines. No one would think nowadays to go to their doctor to get a non-sedating antihistamine or a proton pump inhibitor. And as someone who trained as a gastroenterologist, I actually like the fact that someone's taken their Nexium over the counter, because then when they come to me, I know all the easy stuff has been done. So my question to you is, from a public health standpoint, as we're trying to integrate the healthcare system, improve public health, what do you see for the value for over-the-counter statins as a first step for those who may not have access to the healthcare system, or who otherwise may not get treated? I'd be interested in your thoughts.
Well, I mean, in the UK, over-the-counter statins was introduced, and it's not proved to be terribly successful. It's more costly than getting it from the National Health Service. I hope you one day have the same situation here. And it hasn't really been picked up. But I think going to the heart of your question, what it reinforces is the safety of the treatment, the fact that it can be over the counter. And that's one of the reasons why the regulatory authorities in the UK did that, because they wanted to reinforce that message. But in terms of making sure that the right people get the statin, I think that having the right guidelines based on the evidence with clinicians guiding that use is really important. And I personally feel the new guidelines here are consistent with the evidence. The idea of thresholds does not make sense when neither the observational epidemiology nor the randomized trials are consistent with a threshold. And the most remarkable thing is that if you've got someone who's got high cholesterol, it's actually easier to lower it. So the ones with the high cholesterol, you give a statin, you'll get a bigger bang for your buck because you get a consistent proportional reduction in LDL with a fixed dose of statin. And therefore, if your LDL cholesterol is 160, and you give a good dose of statin, you'll get it down by 80, so that's a 40% reduction in risk. But if it's only 80, you'll get it down to 40, so you'll only get a 20% reduction. So it's a very nice drug in a way. The people who have the most to gain can get the most from giving them these standard regimens. And instead of titrating up, what we're doing is using the LDL to test compliance, and really doing that quite crudely. Are they taking it? Well, the cholesterol should come down. and titrating against the very rare side effects, because it is true that myopathy risk does increase with more intensive statins, although less so with atorvastatin and rosuvastatin within the range used. But if someone gets a problem, then you titrate down, but not on the basis of the LDL, on the basis of are they having side effects.
I think we're just about out of time, but let me just summarize a little bit how I think about this. If someone has a myocardial infarction with an LDL of 150, let's say they have a heart attack at age 60, I think they've actually got pretty resistant arteries because they've made it to age 60 until they have their heart attack. Someone who has, so they may not actually need as much lowering. Somebody who has a heart attack at age, with an LDL of 80, somehow has weak arteries, whether they're inflammation prone or whatever, they have arterial weakness. They actually need a much lower LDL. That would be my way of looking at it. The fact is that an arbitrary target is certainly not right for everyone. So if someone has a heart attack with an LDL of 80, just to lower them to 70, it would be inadequate. All right, well, listen, I want to thank the panel for a really informed discussion. I think the audience should know that you're listening to the real experts. This is not some guys walking off the street giving their opinion. These people have thought about this a great deal. And I'd really like to thank them for coming and thank the audience for coming at this very early hour. And now we'll go on to the next panel. Thank you.